Hello, my name is Dr. Sarah Cole. I'm an orthopaedic surgeon based in Cairns in far north Queensland. And tonight we're going to learn all about lymphedema and oncology rehab. I feel like you've been waiting a while to present this. I feel like you're excited.
Oh, yes.
Is that fair?
Yes.
Good.
Okay. Thank you for having me here to talk about the oncology rehab and lymphedema. First, we'll be touching base on about oncology rehab, and then I'll talk a little bit more in detail about lymphedema. So first I'll start off with talking about the diagnosis and survivorship in Australia. This is a graph between 2000 and 2024. We can see that incidence rate is the diagnosis rate. These are going up as the years go by, and the mortality rate is coming down. And you can just expect that everything is, there's much more earlier diagnosis happening, and the technology is getting better these days, so the mortality is increasing. The 5-year survivorship in 1991 to 1995 was 55%. Whereas now, it has increased to 71%, so that's a really, really big jump. So cancer has shifted from being a rare condition to a condition to live along with. So when we think about it, 1 in 22 Australian is now living with cancer. And one of the reasons is we're living longer. Asian population, the longer we live, the more higher rate of having a cancer, and the change in our diets, westernized like fatty foods, those will change the risk of having a cancer as well. And like I mentioned earlier, earlier diagnosis and screening is taking place. So people are being found with early stage cancers compared to the past. And of course, chemotherapy, treatment-wise, radiation, everything is getting better, so there's more incidence of people having a better mortality rate. So this basically means that whenever we see someone, being it musculoskeletal condition or neurological, they might be in chronic pain, but it's highly likely that they may have had cancer or will have cancer in the future. And it's, I think it'll be good to understand what's going to happen when they're diagnosed and going through the treatment. So I hope to touch a little bit more into that. So what happens to the body during the treatment? So treatment is different for everyone. Not everyone has chemotherapy, not everyone has surgery, not everyone has radiation. But I'm just going to talk a little bit into the chemotherapy of what's going to happen during the treatment. So usually they would have chemotherapy, sorry, it says cancer related, but it's chemotherapy related fatigue, nauseous and vomiting. And this will affect the ability for them to stay active. It will affect the ability to eat well. And this can lead to muscle loss and weakness. But not only that, the cancer is has an inflammation effect, and it's going to cause muscles to atrophy. So it can be with the treatment or it can be from the cancer itself. Peripheral neuropathy is another side effect, which causes numbness and tingling sensation in the hand and foot. It's going to affect their ability to do things with their hands, also increase the risk of falls. Some of the chemotherapy can cause cardiotoxicity, so it just causes an overload on their heart, and it can impact their capacity to move around. And there's a lot more small and big side effects. And these all basically reduces their physical function, which is going to affect their quality of life and how independent they can be. So it is very important for us to understand that what exercise can do to help these conditions as well, because muscle is going to be helpful for these conditions. So I think in the past, when you have chemotherapy, when you have surgery, everyone would say, take it slow, have a bed rest, don't move around too much. In fact, that is not good for your body, for anyone, because from this graph, we can see that the longer you have bed rest, the more that you're going to lose your muscles. So there's the theory of use it or lose it, and bed rest will cause 2 to 5% of decrease of the muscle mass per day. It's a per day, and you can lose up to 10% per week. And it drops so quickly, but then it can take up to 12 weeks for the muscles to start rebuilding. So it can drop down 10% in 10 days, and then it's gonna take you 12 weeks to build it back up.
Is that because they take 12 weeks to get moving, or are you saying that even if they try and get going, they're still not, their body's not going to respond effectively?
So generally from like the mechanism of building muscles up, there's like a concept of like
lag.
Yes. So it would be for anyone, not just cancer patients. Yes. So what is the best method to prevent this? Of course, we want to build muscles as much as we can when we can, and it's very important for you to move when you feel like you need to rest as well. So exercise is going to be a key for positive impact to your body during and after your treatment. So muscle is important, in fact, in the context of staying active. But we've also found out that amino acid that's released from the muscle gives positive impact to the immune system as well. There's a lot of interleukin, but this interleukin 15 actually stimulates the natural killer cell. Okay, and natural killer cells are very strong against cancer and tumor. So when they're stimulated, they can fight against cancers. So the more muscles you have, the more of those interleukin is released out. That's going to help your natural killer cell fight against the tumors. So it is very important for you to have those muscles, even when you're not diagnosed of cancer. So if I'm going to talk about how exercise can help with the side effect, one of the biggest side effects of chemotherapy is fatigue. So there was a study done where they had a control group A and B. One of the control group A was given quite a strong menu of 50 to 70% of maximum heart rate exercise between Borg 11 to 13. So that's about like a little bit hard exercise, not too easy, not too hard. And they were asked to do that for 20 to 40 minutes, 5 times per week. So they were actually like led through those exercises. While the control group B, they were just told to stay active and given a stretch exercise. And they tried to see how it affected their fatigue. And the outcome was actually very good, because with the intervention group, this one shows the level of fatigue, but you can see that after intervention, that level of fatigue has dropped greatly compared to the control. So they did a lot of those aerobic exercises, and it shows that it helps the fatigue. But at the same time, because they've been pushed to the level of doing an exercise that's not too easy but not too hard, the amount of distance they can walk with the 6-minute walk test has also increased, which means that their endurance went up when their fatigue went down, which is a great outcome. Another one is nauseousness and some vomiting, and there has been a study done to see what kind of exercise would help fatigue and nauseousness, and we already know that the fatigue exercise helps with the fatigue. But with the nauseousness, they say the resistance, when they did the resistance training, 75% improved. Unfortunately, 19% said it just got worse immediately. When they do an aerobic exercise, 71% improved and 7% said they worsened immediately. So for the fatigue, aerobic exercise is a go-to. But for the for the exercise for nauseousness, it's going to depend on that person. Someone can react really well to aerobic, someone can react really well to resistance. Some may need to have some additional medications to control it. So if I'm going to summarize the exercise modalities, for Cardiovascular training, aerobic exercises, they're wonderful for building endurance, decreasing fatigue, and helping with the nauseousness depending on that person. When we think about strengthening, it's going to be very helpful for building muscles, which I told earlier that they have quite a lot of good positive effect on your body. It may help decrease the nauseousness, but it's going to help you maintain your overall function and strength. And lastly, another type of exercise that would be helpful would be the balance exercises. This is going to focus a little bit more around that peripheral neuropathy because we don't want anyone to be falling, and then it's just going to help prevent those falls as well. So when we think of the exercises across the cancer journey, we want to be in touch with them and help them even before treatment, because this is the only time that we can actually push them to build those muscles that we need. So we call it rehabilitation, and this is the timing that you can build as much as possible. When they're going through any kind of treatment, they're going to have fatigue, they're going to have symptoms. We just need to tell them to stay active as much as possible. Try to use those evidences because it's actually true. I've seen people, they start off really fatigued, not wanting to do any physio. We start off with gentle walk, and then we can actually finish out through the whole menu that they did before the treatment as well. So it's going to be helpful. So you just need to give those positive push for them.
Is that you're describing in a single session? You take them
in a single session, yes. It will change in the single session. That fatigue is a big one to change, yes. And then after they're done with the treatment, it's really important for them to continue the rehab, build the strength and functions, because they need to go back to doing what they love to do. And another reason why they need to continue the exercises is there are a lot of conditions that cancer patients, cancer survivors can have post-treatment. One of the big symptoms would be lymphedema, which I'll be talking about later. But high risk of osteoporosis, simply from radiation or chemotherapy, hormonal therapy, and it's very important for them to start early for the bone health exercises. Some can go into sarcopenia, that means the muscle mass decreases, and we just need to continue strengthening them up for them. Okay, so now I would like to talk about lymphedema, which is one of the topics that I love to work with. So first we need to think about what lymphatic system is. It's made from lymph fluid, lymph vessels, and lymph nodes. Basically, they are carrying your wastes, they are carrying your immune cells to protect your body, as well as maintain fluid circulations. So if you can see on the right diagram, you can see that there's the capillary, the fluid will come out, protein will seep out, and the lymph vessel are the ones to take them in and then put it back into the system. So that's the lymphatic system. And lymphedema is a condition where when that pathway or that system where they need to bring back in the fluid is blocked, damaged, or gone, and those fluids don't have any places to go, and it starts swelling. So this is a interesting picture from one of the studies where they took a photo of each lymph vessels at different stages. So at stage 0, you can actually see that it's very thin and clear. That's the healthy lymph vessels. And as more loads get put onto that lymph vessel, it starts to stretch out. And that makes it harder for those fluids to go in because it's stretched out. And then if that continues, it starts to change it into a thicker wall. And if it becomes thick, you can just imagine that there's not going to be a lot of fluid going back in, unfortunately. And when it reaches full, we call it a sclerosis type. So it's very sclerotic, it doesn't change. So that's the changes that's going to happen when you don't treat the lymphedema at an early stage. So what causes the system to be damaged? There are different ways that the systems can actually be damaged, and all chronic oedemas shows that lymph system is either one, not coping with the volume of fluid that needs to be transported by a given time. So if you can think of a bucket that's been giving more water, before they can get drained out, it's just going to start overflowing. So this would be, example that I can give would be heart failure, kidney failure, if you have high blood pressure, venous insufficiency, oedema post-surgery or injuries, that can fall into that. Another one is they're not able to function correctly. So basically their transportation method is reduced greatly. So if you can think of a car accident or a roadblock where they're not allowed to go through, that causes that swelling to just increase and increase. And how you can get that is through lymph vessel malformation, damage to the lymph vessel or nodes through surgery, radiation, or even injuries. There are two types of lymphedemas. There's one called primary lymphedema. It's a rare condition where you're usually born with it, and that can be present from adolescent to early adulthood. Usually they have a genetic condition, and the lymph vessel can be in a wrong spot. They don't have enough lymph vessels, or it can just keep creating in areas that doesn't pump correctly. And it's pretty, I think I will talk about it later, but it's a rare condition. Secondary lymphedema is something that we would see much more often. So malignant secondary lymphedema is more with cancer-related treatment. So it'll be surgery that took out some lymph nodes, radiation to the lymph nodes, chemotherapy. Those ones can cause secondary lymphedema. There is also the non-malignant secondary lymphedema, which means that the oedema, the swelling, stayed in that area for over 3 months, which leads to becoming a lymphedema. Yes. So this would be more around like venous insufficiency, heart failure, kidneys, wounds that are difficult to heal, and post-injury surgery, peripheral neuropathy. When you have that swelling for some reason and that continues for over 3 months, it turns into a lymphedema. So I have a few photos and diagrams of the secondary lymphedema. Some of my clients were very nice to allow me to share their photos. So the first photo right here, she has a peripheral neuropathy for over 20 years. She did have slight swelling, but it was not bad until she broke her tibia. And she has also comorbidity of the diabetes, and it took her 12 months for the bones to start connecting. So over that 12, did I say 12 months? Mm-hmm. 12 weeks. 12 weeks for it to start healing. And that is three months of swelling. And now she has a swelling in the left side, not the right side. So she has a little bit of a both component mixed in. But the thing that actually pushed her to have a lymphedema was that fracture that was difficult to heal. This second photo, you can see swelling a little bit around here. You might see it more on the screen, but you can see that you can't see her knuckles. So she does already have a garment, but hers is secondary to cancer treatment. She took out 20 lymph nodes, and the swelling was seen right away. And in her case, she thought the swelling was getting better. She took off the garments, and then the swelling came back. So we just took the photo of that. I just have this diagram for an example of sprained ankle. I don't think anyone's gonna have like this much swelling around here. But if that sprained ankle or stays swollen for over a long time, they sprain it over and over, or that swelling just doesn't go down, it's going to lead to becoming a lymphedema. One thing that I myself didn't know as well is obesity can actually lead to lymphedema as well. because when you can see from the legs, if it's big, it's going to put a lot of pressure onto that lymphatic vessels, and whatever that overloads the lymph system for over long time, it is going to turn into a lymphedema. This is like just a photo of the venous insufficiency. So you can actually change into lymphedema around here. Okay, so if you have varicose veins, okay, you're at the stage before your legs start swelling. So it's already good at the end of the day if you feel your legs swelling, you see varicose vein, it's already good to think about having those like light compressions on, just for prevention as well. So the incidence of lymphedema, primarily lymphedema, they say 1 in every 6,000 would develop lymphedema. For the secondary lymphedema, the Lymphedema Association of Australia estimates 70K. And it's an estimate because people don't notice that they have lymphedema, or they don't say that they have lymphedema. So it's just an estimate, and some say there's more than that. With the cancer related, National Breast Cancer and Ovarian Cancer Center estimates 20% of breast, genitourinary, gynecological, or melanoma survivors are prone to having a lymphedema. With the breast cancer patients, they say between 49 to 50%. So you can kind of expect half of the person to start adapting or having a lymphedema. It's quite a big number.
Is that to do with the number of lymph nodes they have?
Yes, so it depends on the risk as well, but not everyone. If you have something to do with the lymph nodes, everyone is at the risk. Yes.
But also they think that there's some sort of predisposition. So some people have a lymphatic system that if you touch it, or the slightest irritation, it just completely shuts down. And some people you can take so many nodes and you're petrified that they're going to get lymphedema, and then just come back in perfectly fine.
Yeah.
So there must be something. Maybe
I was fascinated by all these secondary and genetic things. That's what I'm here like looking at.
Yeah.
So I would just like, if you're going to take away something, I really want you to remember this because it's very important. So this is the diagram of the lymphedema stages. You saw earlier that lymphatic change in the lymphatic vessels. So at stage 0, there's no swelling, there's no visual. You can only tell through machines. Stage 1, you start to see swelling. There will be pitting edema. You raise it up, the swelling goes down. That's the stage 1. And when it goes to stage 2 and 3, the skin texture starts changing. You're not going to get the pitting edema because it's very hard. And it's also even going to start changing your fat tissues as well. So like you can see here, we call it an elephant skin because it's going to be very thick and hard, and you will not get a pitting edema here. Why I ask you to remember this is there's a center line. And it's important because from here, if you catch it here, wonderful. Stage 1, early stage, we might be still able to reverse it. When it goes to stage 2 and 3, it's irreversible. It's a condition that you're gonna have to manage throughout life. And not many people know that it's reversible, and it actually is. So why is it important to prevent lymphedema or like catch it at an early stage so we can reverse it? It's pretty obvious that it's going to affect them physically and mentally. If their arm's swelling and they need to have that garment, it's gonna be a lot of load on them. They already have a lot of load from the cancer treatment. It can cause fatigue and lack of energy because lymphedema is a condition of inflammation. Inflammation continuously in your body, it's going to cause you to have a lack of energy. You're also going to have a high risk of cellulitis, which can be quite deadly if you leave it as. And when I mentioned that there will be a tissue change and the fat tissue is going to change, it's going to get bigger, the only way to change that is liposuction. And that's not to fix the lymphedema, it's just to help with the change in the skin textures. Okay, so that's more of a physical, mental load. But I do also want to share the financial load for the management of lymphedema is great. With the treatment phase, the bandaging, decompression, it's going to cost between this price, and they need to pay for the treatment sessions. And then even after they're done with that decongestive phase, which I'll talk about later, the compression garment can vary between $150 to $600, and they will require 2 sets of it, one for washing and one for using. And these compression garments is actually recommended to change every 6 months. So if you can already think of how much financial things that's going to come into them, because they're probably going to, if they have like a whole leg, $1,200 every year going by. Some may also require a night garment where you put it on at night, and that is much more expensive than the day garments. Some may require a compression pump to help them at home to bring down the swelling. That mimics the lymphatic massage, and it's that price because it's going to be machines compressing. And they would also need to have a don and doffing aid because it's not easy to put it on, unfortunately. So if you can think of all these things, that what would have happened if we could have caught it early stage and reversed it, I think it's very important to understand that as well. Early stage, unfortunately, the symptoms will vary between people. It can be heavy. They can say it's heavy. They can say, oh no, I'm feeling like this part's hot. It feels full, it's painful. They come with different symptoms. And it's just very important for like both patients and us allied health professionals to listen to the body sign, because if you feel something's different, there's something going on. And I think it's worth going into an investigation to see if you're adapting like an early stage lymphedema or not. So with the assessment, I've been talking about there's no swelling at stage 0. How do we detect it? There is machines out there, bioimpedance, LDEX and Embodied. So they check the amount of fluid accumulation that we can't see visually. And they would be able to tell us if there's already swelling starting to happen. With the objective assessment, we go with measurements. We touch, see if there's any oedema, there's a stemmer sign, and we observe like how the skin is and those stuff as well. There is an Indo-Cyan green lymphogeographic. Have anyone heard about that? Yes, okay, awesome. So they inject in the ICG from like here, and they use a special light to see where the lymph flows through. When it doesn't work well, so this is stage 0, you don't see any ICG here. Stage 1, you see a little bit of an accumulation of the lymph, like difficulty of this ICG going through the lymphatic system. And then you can see from the 3rd and the 4th, like the 4th one, it's not going anywhere. Okay, so this is like a good one to see if you have lymphedema or not, or if you do have lymphedema, it's going to be very helpful because we know where the lymph works. So we would be able to map out where these lymph fluids would flow into. I think they do it at the Macquarie University, yes. Another thing that's important for lymphedema is to rule out red flags. So if they have any heart conditions, is their blood pressure okay? Is their renal function okay? If it's a one-sided swelling, do they have DVT? So those are quite an important one to think about for the assessments. But with all of this, other than the ICG and the red flag, it is very, very ideal to have the baseline before treatment, any treatment. Because even with chemotherapy, that's going to change the amount of fluid in your body. So when they're diagnosed and before they start treatment, it's ideal that they jump on those bioimpedance, LDEX or the Embodied to have a base measurement. So what can increase the risk? A lot of stuff. If we go with the surgery, the amount of lymph nodes taken out. The more that's taken out, the more risk you have. Radiation, if you radiate on the lymph node, that's going to increase the risk. Chemotherapy, they do say that these two types a little bit more can increase the risk. So if you have a breast cancer client that did all of this, took out 20 lymph nodes, it already kind of gives you an idea to keep an eye on the swelling as well. If they also have an axillary web syndrome, that can also increase the risk because this is a condition with the lymphatic system. If they have any underlying venous insufficiency, or if they're obese or had trauma, history of cellulitis, those can all add into that risk. With people who are at risk in their daily life, skin irritation is one thing that can trigger or make it worse. Bug bites, which is hard to prevent in Cairns. Sunburn is also hard in Australia. But these are something that you do want to prevent as much as possible. So before starting treatment, I do need to clear out these things for safety reason. I just wanted to share that. We want to make sure that their artery is happy if we're going to compress the legs. So ankle brachial index, toe pressure with Doppler duplex ultrasound would be good. And we also need that to rule out that red flag. So let's talk about where we start. So first we need to bring down the swelling. So we call this the decongestive phase. It's gonna be between 1 to 2 weeks or 2 to 3 times a week. Lovely photo of my leg and Maggie's arm. So this actually has 2 layers of bandages. Very, very strong. I was in pain when they did it. So you just need to tell them that it's not comfortable, but they need to go into it and then they need to move, and that's going to bring down the swellings. Mm-hmm. So when the swelling comes down, they come into the clinic, we rebandage, swelling comes down, come back into the clinic, rebandage, and usually it should calm down as much as it can into 2 weeks. Some people can take 3 weeks depending on their stage of lymphedema. At the same time, we also start lymphatic massage, which they can also do at home to get those fluids moving. After we bring down the swelling, what do we do? Prescription of the compression garment. So day garment is to contain the swelling during the day. Night garment is to contain the swelling and produce lymphatic flow during the night. Some people can wake up with swollen legs and swollen hands. They would need a compression garment to move those fluids over the night.
Do they all need a night one?
No.
Oh, okay.
So if they do have swelling in the morning, it means that they're refilling very quickly over the night. So you want to keep that lymphatic flow going over the night as well. So during the day, it stays down and you have to redo everything in the morning. That's not ideal. So right now, there's a few companies out there doing the garments, and it's getting much more fashionable. There's like a bright pink, Jobs does a really good job with these kind of colors. They have orange, they're making it customized with like different words that you can actually put in to the band. It's like fight or something like that. You can actually customize it. So it's getting very fashionable. So these are the normal garments, knee high, thigh, all the way to the arm. This middle one is the one that I really love. I don't have this brand, but I do have a different brand garment. It's called a wrap. So what happens is you undo everything, all the Velcro, and then you just put it on, and then that swelling goes down. You undo it, and you put it on, and that swelling goes down. So it's like a 2-in-1 garment of the bandaging. It's very good for regional areas where they can't come and see you that often. So this is a really good one. It's also very good when your carer is old or have difficulty putting the compression garment on. The last one is the night garment. They're the most popular in my world. A lot of people say that they're good. There are other night garments out there as well, but they're from Hadenham. This pattern actually makes those fluid movements. So it doesn't have as much pressure as the day garment, but it drains a lot during the night. Other modalities that we can use, taping tape is great. It's going to help move the lymphatic fluids by lifting off the skins. Shock waves are something that's under research right now, but they do say that it helps create new lymphatic vessels generated. And for lymphedema clients, not lymphedema, but lymphedema clients, it's helpful for their pain as well. So that's something that's starting to get more popular. We also have the low level laser. It doesn't generate heat, which is not good for lymphedema, and it just helps the circulation. It breaks down the fibrosis, so lasers are quite used frequently in the treatment. Mild hyperbaric oxygen chamber is also starting to have some research done for more of the effect of creating new vessels, like lymphogenesis, as they have a long-term outcome for that as well. The compression pump is quite popular for people who wants to manage the swelling at home. It tries to mimic the manual lymphatic drainage at home. So they basically, if they have this, they have like that lymphatic drainage every day for an hour. Yeah. Another wonderful thing is called a chip bag. One thing is don't Google chip bag because all they give you is Doritos. But it's called a chip bag because you're going to use different shapes, different density foams. And what happens is when you put it into the area that's a little bit fibrotic or swelling, it actually helps move those fluids out quite well. So this is what I use in clinic. Clark Rubber Shop got me this. Like I got this from the Clark Rubber Shop. But they also have. I also use a kinesio tape, and I put it on the tape, sandwich it, and then it makes a little bit of patterns like this as well.
And then what do you do?
And then what do I do? So if there's a swelling here, and they have the garments, we slide that into the garment over here. And that's going to provide a very random pressure that the lymph likes. And they start to drain out, they start to move much more. And with the 1 day of the chip bag use, you can actually see a really big difference. So right here, you can't see her tendons. Right here, you can actually see them. So this is just 1 day of a use. And it's very easy to make.
What is it?
Chip bag.
Is that why you got Clara's sister to put a dishcloth on?
Yes.
Is that her hand?
Yes.
Oh yeah.
Yes.
Clara's sister has breast cancer.
Oh, I was going to say, did you create
she wasn't just
pathology?
randomly.
You
no,
weren't trying to create pathology.
So if you
That's not a secret. She's posted it on her Facebook page.
yeah.
So yeah.
So you're trying to create that thing in the top right-hand corner that
yes,
goes.
but it's homemade.
Yes, that goes inside the garment.
Yes. So you stick it under it. Inside, under? Yes. So I've actually used it for one of my chronic oedema client, and it worked really well. I just asked her to shove it in she had a swelling around the foot, shove it in the socks and put your shoes on, and it actually helped the swelling a lot as
Because
well. So.
Amelia didn't even have a compression garment, right?
No, she did.
Oh, she did.
She did have it, but her hand just didn't stop swelling. So we just added that chip bag into it. And yes, you can also look up on YouTube. There's a couple of people making it. But it's very easy to make, cheap to make as well.
And what's the theory about why random pressure helps? Why are you trying to create why not a pattern? I mean, I guess.
I'm pretty sure that the pattern works better because what they make is all patternized. This is all a product from the compression garment. But then there's also the difference between like if it's random and if it's harder and softer, it kind of makes that movement
of the
fluids. Yes.
Like
garments.
So it, you know, like if there's a lot of push there, it pushes out, and then it's like making the rivers flow.
And is it better if they move their hand more?
Yes, always.
Right. So why aren't we doing this little post-operative?
You can make.
Make
Make a chip bag.
Okay,
Make
go
it
on.
Yes, so that was actually like the big change that surprised me as well. I was like, ooh, cool. Another case that I have, so she came in for something completely different than lymphedema, and she has a history of left hemiplegia. And she suddenly came to me and said, my legs are swelling and it feels weird. And I'm just like, yeah, tell me more about it. Why is it swelling? Like, what do you think? And she says, oh, I had a radiation. And I'm just like, oh, I never knew that. So she had a radiation straight to her inguinal lymph nodes, and her right foot feels weird. Red flags were ruled out. ABI with Doppler was all great. And actually, like when I asked her, she did have a compression garment that was prescribed to her, but because of her hemiplegia and it was just difficult to put on, and she just like probably put it somewhere that she can't find anymore. So this time we actually got her a Sigvaris compreflex. It's the same wrap as before, but this one you can actually adjust the pressure between class 1 to class 3, which is great. And she uses 4 hours per day depending on her schedule. She says she doesn't want to put it on when she goes out, so I'm just, yeah, that's all good. So she puts it on her legs when she's at home, and then her husband does a daily lymphatic massage on her. And another reason why I chose this is because it'll be her husband putting the compression garment on, and it needs to be easy. It needs to be sustainable for them to do it every day. And we actually got a really good outcome from it. So just to keep it clear, the compression garment is only on the right side. They wanted to try one side first, but we still saw a difference in the left side as well. I'm not sure, can you see? So the biggest difference was seen 30 centimeters above the malleolus, so around here, with 3.2 centimeters of a decrease in 2 months of the use of the compression garment. Meanwhile, her husband has been doing a lot of lymphatic massage on the left side, which is why so many difference was seen on this side as well. 2 centimeters just from the lymphatic massage is really good. So we've had quite good one. I'll be catching up with her soon, but yes, it's just the effect of the compression garment.
What's lymphatic massage?
Lymphatic massage is when we want to use our manual therapy to move those fluids into the lymph nodes.
And
so
yeah, do you sort of try and increase the surface area of the hands that you massage?
it's more pulling those fluids towards the lymph nodes where it can drain.
It's not like a muscle. It's not deep.
It's
quite
not deep.
shallow.
It's shallow. It's
Yeah.
shallow, but it's firm.
Okay.
Yes.
And it's more of a sweep and a drag,
Sweep and a
rather
drag.
than a
Yes,
well,
yes.
a
Well,
typical massage.
if it becomes very fibrotic, like those
Sure.
photos from 3 to 4, you do
Mm.
need to go quite hard.
Mm.
Like I would even like kind of
Oh,
push,
okay.
push,
Like a
push.
muscle massage.
But
the
now,
fibrotic ones, is there more of a case for shockwave?
yes, that is still a little
It's
bit
still
under
a
my
little bit,
research
yeah.
because there's 2 types of the shockwave.
Yeah.
And radio doesn't work as well as the. Sorry, I can't remember that.
Yeah.
So
The
there's
one
2
that-
types,
yeah.
but
Yeah, sure.
radio doesn't
Yeah.
have much evidence compared to the other ones.
Okay.
But laser would be a great one to do before the lymphatic massage because it breaks down the fibrosis.
Really?
Yes, they're wonderful. So, of course, compression garment is important, but after that, you do need to exercise because if we think of how the lymphatic fluid moves is with the muscles. So exercise should be conducted after opening up the lymphatic system. So you want to do a lot of deep breathing, wiggle around the lymph area, okay? And then you're going to kind of alert and wake up the lymphatic system. And before they did say you need to do it with compression garment on so that you have that pressure that just adds on more effective draining. Now they say there's no evidence saying that it's much more effective compared to having the compression garment on. Compression bandage is a little bit of a different story, so I'm sorry about that. But if someone feels much better taking it off and doing the exercises, they are now saying take it off. There's no evidence that it's going to drain more compared to when you don't have the garment. So their thinking is changing. In the past, they said don't lift heavy things. It's like, how heavy is heavy things? But like some people were told don't lift 2 kilograms of dumbbells, don't lift more than 2 kilograms. Now it's being said, no, do exercise, lift weights. You just need to be careful that it needs to be a gradual load because we don't want to overload the lymphatic system. So someone who hasn't done exercise shouldn't go off and use 8 kilograms, 10 kilograms dumbbell. Someone who has been doing exercise that does 6, 7 kilograms, it's like, yes, go for it.
Would you want them to do more dynamic stuff though, rather than sort of 1 rep max?
No, dynamic, yes.
Yeah.
Rather than one, because we want that muscle contraction muscle pump to work. So that would be how you can actually talk to them about the exercises. With the management, it's very simple. Do everything to offload the lymphatic system. So you don't want additional infection. You don't want the guts to be all nice and angry after eating fatty food and alcohol. So skincare, they say Megumu is great. Eat well, and then just have an understanding that the treatment is ongoing. It is a condition that cannot be reversed once in stage 2 to 3, and it's very important to educate them because high possibility swelling goes down, they take it off and it gets worse. Okay, so that's a very important thing to talk about considering management. If I can also talk about the Queensland scheme at the end. So I talked about the financial load on each patient, but there is a scheme that the Queensland have, and it must be prescribed by an eligible allied health professional, which will be people on the Australian Lymphology Association, so you can search for them. And those eligible to having this scheme would be people clients with on pension card or healthcare card, and then they also. Yes, I can do it. Yeah, and eligible for Medicare, and then up to 2 garments per limb every 6 months. So 1 for washing, 1 for using, or someone can order the night garment and day garments. That's 1 as well. So this is there as well. Yes, thank you. I already had a few questions, but if there's any additional questions.
Oh yeah, I've got more. The muscle loss that you spoke about at the beginning worries me. I mean, I've certainly seen, big strong guys come in after motor vehicle accidents, and they're just, that 10% per week. Once we put them on in traction and things like that. Have you got some examples where you've seen that sort of sudden muscle loss, or cases that you've sort of seen a patient and then seen them, 2 weeks later and thought, oh my goodness, how did they lose so much muscle so fast? Like people you've treated a bit more regularly.
So, not much of a visual changes with oncology clients. But I did work in the orthopedic wards.
Yeah, sure.
Our system in Japan is quite different. Everyone will be hospitalized. If you have a fracture, it's about a month of a hospitalization. And you can actually see the deconditioning because of that non-weight bearing and those stuff as well. You can actually see the muscles change as well. So maybe for a month might be too much.
So you're saying once they're in hospital, they are socialised to move less? Is that what you mean? You're saying that they just move less because they're in hospital, regardless?
Yes,
regardless of the fracture.
Regardless of the fracture, 100%, because their life is finished around their bed.
Yeah.
They have the TVs there, beds there, people would bring food. I'm not sure if they bring food here, but food would be delivered. And yes, 100%. In my hospital that I worked in, most of the clients have physios because of the deconditioning risk. So even if they come in for diabetes, education, physio.
What's the age range of people going to the classes and so on at Couch? Somebody asked me about this a while ago.
Ah,
She's going to look
age.
into it. She's in her
I'm not
20s.
sure, but between like 40 to, I don't know, how old? See, 80? 70?
Yeah.
Yeah. Yes. Oh, I haven't mentioned much about couch today.
Do you want to tell us a bit about Couch? What are you doing there?
So Couch is the cancer care hub. It's a wonderful hub for clients that's been diagnosed with cancer, care, family, everyone, just to come together. And I'm usually there to supervise the gym session class. From next week, I'll be moving into my little room to do physio and remedial. Yes, as well. And yes, it's actually really good. They have Pilates, breath and chi, stay strong class, heaps of different classes, a lot of workshop as well. Yes.
And you feel like it's an effective model for this group of patients? Is that what you
Yes, 100%. Because there's a lot of people with cancer who doesn't know who to talk to or what's
Correct.
going to happen. And it's a different nuance of story to hear from someone who went through it rather than from like someone who hasn't. So like it's very like sometimes I see my clients talk to them about like what kind of treatment they went through and those stuff, and I think it just gives a little bit more of a different message. And yes,
okay.
no, it's really good. Yes. And the fact that gym class, we even have carers, like family members, so it's like a mixture of people with cancer and without cancer, and I think that kind of like atmosphere is really great there. Yes.
It's just interesting to hear you talk about Couch when you've just talked about that hospital model, you know, and then here we have almost the opposite. I mean, obviously people have to come together, and the benefit of a hospital is that it brings the patients to the team.
Yes.
Right, so that's the utility of the model, right? But you're saying, you know, you bring them in, but you bring their families in. There's a lot of opposition to that, and that's relevant in the maternity ward. So when a baby is born, the father doesn't get an ID. The father doesn't get an ID number. The mother does, and the baby does, but the father doesn't, right? So you're describing that you've got a very healthy, psychologically healthy model, which is this interaction with previous patients, current patients, or so previous cancer survivors and their families.
Yes. I mean,
And
like
their care
it is a
providers.
lot of like load on the carer as well, like a lot.
Sure.
Yes, and then sometimes it's good for them to go there and just do what they like to do and get some support. There is a lot of support for people who have been like cancer survivors, but I think the thing about Couch is they really try to help out the carers as well. Like it's really good.
Yeah, I think it's really good. I think it's what we should be aiming for.
Yes.
Yeah.
But one thing that I thought was funny was in Japan, chemotherapy, you get hospitalized, of course. With the surgeries, you get hospitalized, and the earliest you can probably get discharged is 14 days after surgeries. And I've been talking about like, you know, no deconditioning, move. But also when I came here, I noticed that there is no one to push those people because they're just sent home in pain, and they just stay home, and then, you know.
Sure.
So I think it's like we need to kind of mix a little bit of getting those physios out there or getting the understanding that they need someone to push them because you can't move when you're in pain or when you're so fatigued. And yeah, I found that quite interesting because I was thinking totally the opposite. You get discharged quickly. A lot of people shouldn't get deconditioned, but actually it still
That's not
happens.
necessarily.
I always find it bizarre in private hospital. I don't know if they still do this, but they would discharge people and send them off to, well, what used to be complete mobility or whatever to get their mobility aids. And I'm like, why don't you just have them here and then put it on their bill? So then you can fit it and then they leave with it. It's like that extra step of having to go and get a walking frame or get whatever
So
you
there's
need.
different funding sources.
Yeah.
So if you're insured and you obtain a piece of equipment from inside the hospital has to fund that, whereas if you're outside the hospital, it's a different funding model.
Yeah.
It's the source of the funding. It's
Yeah.
not which takes you back exactly to Couch, because now we've seen a good model.
Yeah.
Where you bring it all together, like you say, there's a hospital, fair enough, you might need some hospitalisation, but then you need community care, which is not just, it's not just you, it's your carer and an opportunity to come together, but then also you need a hospital in the home effectively, which is that
the fact that Couch still have that level of community support, that they can keep that going even after they lost
Yes, exactly.
a ton of their government funding, pretty much all their government funding.
Well, because it doesn't fit the model.
Yeah.
It can't fit the model.
Yeah.
And I think that's important. That
Yeah.
It doesn't fit the model.
Yeah, I know they struggled around COVID because they had I think they had a lot more alternative things around COVID, and
They've had to scale it back.
yeah, those things weren't allowed to happen, or like people didn't want to get vaccinated, or there was a whole
It was
lot of
complex.
things that, yeah.
How long have you been involved at Couch?
10 months.
Okay, yes, okay,
I-
so a year or so, yeah, okay, good. So you said, I love lymphedema. So why do you love lymphedema? I love how much she answered.
Is it more from like a clinical or like?
Do you love the results you get? You know, I love carpal tunnel releases because the patient always tells me I'm fabulous, right? Because they're so happy with the result, right? So sometimes I love that, but I love the technical aspect as well.
Yes. Well, it's very, I think, a really nice thing to be able to help someone have their body image back, be happy, go out, enjoy what they were enjoying. So I've had a couple of like episodes where legs swollen, I like going out, but people look at my leg, I don't want to do it. And then you can help them bring down the swelling. Yes, they might have to wear the compression garment, but they can hide it with their pants. And the fact that it can help those quality of life is what we want to do, right? And I think it's one of like the good ones. But also, I love the feeling of the fibrosis getting softer, the skin's softer. So you start off with a really tight one. It's tight, it's heavy, it's thick, and then the more you swipe across it, it gets like softer and softer.
What, in one session or?
Yes,
You can see-
in
you
one.
can feel
Well, it
change.
depends on that person.
Sure, but you can feel changes quite quickly.
Yes. And I'm always like,
Really?
look, touch here.
Yeah.
You touch it, it's like, oh, it is softer. You know, and I just love that feeling as well. But the reason why I started off wanting to treat is more of helping them with the quality of life. Yes. Yeah.
So it sounds like what you're saying to us is that you get quite a significant change in their quality of life with this treatment.
Yes.
Yeah.
Yes.
Rapid and quick.
Yes,
Yeah,
yes.
rapid and effective. You mentioned Turner syndrome.
I didn't read
You
it out,
mentioned
but
Turner
yes,
syndrome
it was
as a risk factor. Yeah.
No.
That was one thing I was Googling. I was like, what? Why?
But the incidence of Turner syndrome is a lot higher than we often understand. So that's the exo carotid. And I think the incidence is probably 1 in 1,000, which is actually quite common for what we deal with. But the problem is if you think that they've got it, then they need genetic testing, which will determine that they are therefore infertile. So it's an ethical question as to whether or not you... Can you see? If you think that they've got it and then you refer someone, you need to think about why it's important. Do you need to know, or do you just treat the lymphedema? Can you understand what I'm saying? So I think you need to treat, regardless of the cause, you need to identify that you've got a patient who's got a genetic cause of the problem.
Yes.
But it's okay to allow yourself to just treat the lymphedema rather than push them into finding out if they've got a genetic condition. Does that make sense?
Well, to diagnose the primary lymphedema is a bit of a tricky one because usually they need to go under genetic testings.
You do
as
send
well.
them for genetic.
Well, like I've never seen one.
So
In the
far?
other lesson, yes. I've met a few people with it, but I haven't actually like
Picked it up.
yes. So it's a lot of history taking
Sure,
with
yeah.
the mom, yes, and then yes.
Would you If you did see somebody with primary lymphedema, would you, I guess, suggest that as an option for something they can consider if they want to? And
Yeah, do you
if they
ever
don't?
refer them back to their GP for when you do you diagnose primary lymphedema sometimes?
Technically, you can.
But
Technically,
have you
actually.
seen much primary lymphedema?
No.
So you always reckon when you see lymphedema, you can usually find the cause. You know it's the lymph node or trauma.
Yes,
you're
well,
pretty
like-
confident.
Yeah.
Right.
So usually it comes from the history.
But your most common patient is secondary lymphedema
Secondary lymphedema.
by a long shot.
Yes.
Yes. Okay. Yeah, I would have thought it too.
I feel like if they were primary, they would maybe come to me as a GP. Like, I don't know
Yeah.
how many people would be searching around going, you'd want to be pretty bad, wouldn't you, to go to a physio first as opposed to...
Yeah.
Going
I was just wondering where they present.
Yeah.
Yeah, just wondering where they present.
Yeah.
We do see that level of puffiness of the foot after ankle fractures. I've definitely seen that. Often they've missed that education about elevating their foot after their fracture. You'd be it's within 12 hours it can be quite significantly swollen. And if you've worked in a hospital, you know that we don't operate on them when they're swollen like that, because you can't actually close the skin.
Yes.
You can't close the skin together because it's too tight. So that's how much tension you've got. Do you understand? Like on the skin, once you've got lymphedema, the tension is, it almost wants to burst, if that makes sense.
Yes.
Is there any point wearing stockings on the plane? Compression stockings on the aeroplane?
Are you talking about the people with the risk or?
No, normal people. Do you wear compression stockings? Yeah. Do you wear compression stockings when you fly?
No, I don't. But it's good for everyone. I mean, everyone can wear a compression stocking right now. It's going to be good for you.
Yeah, you like them that much. Yeah, they're that good.
Yeah.
Okay.
You should say about the having to get clearance from the chemist to buy that particular type of stocking.
Yes, I have recommended someone with the swelling to get a class 2.
Yes.
So the second grade, about 20-30 mmHg.
Millimeters of mercury.
Millimeters of mercury.
Yeah.
And it ended up that Physio needed to write a letter of recommendation, or was it a prescription?
Yeah, well,
Yes.
it's a letter of recommendation for the
Yes, to
chemist.
purchase it because she couldn't buy it just off
She
the
wasn't
shelf.
allowed to buy it?
Yeah,
No.
yeah. So she rang, she was down in Chemist Warehouse. Luckily I answered the phone, I'm like, Megumu, what did you want her to get?
Wow.
Yes.
Because the
So-
compression was so intense.
No, I think it's going to be a medical grade, class 2. So
Yeah.
yes. So class 1 is for everyone.
Mm.
Anyone can wear it, but yes.
Yeah, okay.
Mm.
Plus, yeah, okay.
Yes, that was interesting.
free
I
to
didn't
ask.
know that as well.
Feel free to ask your questions. I always just try and make sure I've got some. Nothing. That's what we're doing, lymphedema.
Yeah. I looked up to see if hypermobility is more of a
And?
risk factor. Yeah.
So like something that I've been talking to my clients who has lipedema is, I think most of my lipedema has hyperflexibility.
Yeah.
No.
And-
Interesting.
Yes, I was very interested in that as well. I wonder if there's any connections.
You should do a PhD.
Yes.
Any connection? Well, no, it
It
must
may
be
be.
something to do with the
Yes.
collagen, surely.
Yes.
But
Yeah.
then what?
And yeah, there's an enormous can of worms, isn't there, underneath that? That's the
Yes.
whole point. Is it just, oh no. Hey?
Collagen type, whole can of worm.
Yeah, enormous. Trying to, here we go.
Risks and then like MCAS and then
Where are we gonna, where is it gonna end?
Yeah.
It's never gonna end.
That's higher rates than the vestibular rates, isn't it?
Oh, people
It's
keep-
like 6,000.
Oh, what is it?
Yeah.
what condition because we
Well, sorry, what was that?
Isn't it like 2% of the population have vestibular symptoms at a given time, or maybe more?
like the recent use, but it depends because it's so like it can be
Yeah.
migraine,
Yeah.
it could be depends what condition you're thinking of.
Yeah.
So it's not like one in one pile. Like
Yeah.
it's like you have to look up specific conditions to see that.
These things that you think are not that common, and then
But I think also working in a regional area, patients don't understand what they can get help for.
yeah,
And they don't know to even ask, and they don't know to even tell you that they've got terrible tinnitus, and
yeah.
you know, maybe they're dizzy as well. They don't even know that it's not normal.
Yeah, I think it's easy.
They think it's aging.
Yeah.
I know.
Yeah.
I know. Oh, I'm just
It's
getting.
not, it's normal.
This is normal, and this is normal, and this is normal, and this is normal. Yeah.
It's not normal.
I do have a question. Like, when you know that you're going to do a surgery on someone,
Yes.
do you actually send them for strengthening, like to build muscles? Or
Rehab.
Prehab.
Well, I must say, I was just doing a total shoulder replacement this week, and I was like, gee, I wish I told this guy to stop lifting weights.
Oh,
Like, you know, like,
how old was it?
he was pretty muscly. He was probably late 60s, sort of 70. It's better at 75 because they've often lost a bit of muscle tone by 75. But 65, I know I'm in for a big day because because you sort of have to get under, because you do a deltopectoral approach, you kind of have to get under deltoid. So you're dislocating the humeral head out from under deltoid. So every retractor is kind of pulling back on deltoid. So if they've got a deltoid, which they don't normally have because they're osteoarthritic, then it's a heavy day, you know. Whereas the majority of patients are late presenting rotator cuff arthropathy, and so they've got very atrophied proximal limbs, and they're osteoporotic. So it's, you know, like it's so. When I operate on an actual rotator cuff arthropathy, I can dissect through their fascia with my finger. I don't have to cut it.
Yeah, I wouldn't have
It just
thought
rips.
you would get many of them that would be ripped.
That would be muscular.
Yeah.
No, they're not often. They can be. I think some of them, you know, have got that no pain, no gain.
Yeah.
You know, they expect pain. Like, it's just I'm getting older, so therefore I'll have pain in my shoulder, so I won't
Just
stop
right.
lifting 50 kilos. I'll just keep lifting it. Now on my back sore too. So I think, you know, I think about prehab a lot. I think I have a very specific cohort, and you know, as a physiotherapist, you can probably see it. By the time they see me, they are ready to go.
Yeah.
You know, they don't want another step in the process, and they are very committed to a surgical solution. And it's very difficult to have a conversation about non-surgical solutions, which I'm uncomfortable with that, but I understand that that's the. You know, it's like trying to send patients home from hospital in Japan. So I understand that that's the paradigm in which I exist. But you know, we do know a lot of things about nutrition as well, because you know they'll come in a bit anemic, or they'll come in very vitamin C deficient. Vitamin D deficiencies are a significant problem in our community. I know it sounds ridiculous, but so we've got the nutritional deficiencies as well as the musculoskeletal balance. Is super hard after surgery, a little bit dehydrated, and if they're just, sometimes when they get arthritic in a joint, they just retreat into themselves. Do you know, they sort of retreat into their home, they retreat into their life, and then someone gives them an operation that's going to fix it, so they just kind of aiming for the operation, and then they think they're through. Collagen, so albumin, if they've got low albumin, that's a huge problem for us, because their wounds won't heal, and they get seromas, so they get fluid accumulation afterwards. One of the things that I struggle with, which is probably relevant, is sometimes when I operate on the shoulder, they'll get a carpal tunnel syndrome. It happens about once every 2 or 3 years post surgery, and they get it at about the 6-8 week mark. It's not while they're in the sling, it's later. Yeah, so I'm sure that there's some sort of, but by the time they present with the carpal tunnel symptoms, it's often they can get acutely swollen later. It's not necessarily while they're resting in the sling. I don't know how much rest they do in the sling.
Is it like a subconscious bracing as well that they're doing if they have like anxiety around moving after surgery and stuff like that?
Yes, I do coach them on that. I mean, you know, I get such a little window of time with them. It's not like you guys get to sort of talk to them. So I do coach them on, you know, body confidence, that sort of thing, you know, like it's okay, and I use a lot of, like I try and use catchphrases because you'll know what I've said because they tell the physio. She said, go for it, you know, so if I think I've got someone who's a little bit nervous, I'll say, you know, you just do whatever you want to do, right? Because I wouldn't do that for every patient. Right, but, you know, I do try and push that confidence in them. If I think, you know, you can see in their tissues that they're starting to get fibrotic, you can, you know, and certainly some people really are predisposed to getting fibrotic very quickly. You know, they're just, you know, one tiny incision and you're just like, where did all that scar tissue come from? I did a trigger finger release, which is a 1 centimetre incision. He had scar tissue from here to here. Like it was, I had to cut it with a pair of scissors. There's no way it would release. Yeah, like I don't know how you're going to massage that up. Like every single bit of skin was attached all the way to the tendon. Right, there's no fat left. So you know how when you're looking at when they've got lymphedema, not so much when they've got the lipedema, but the fibrous tissue is so hard and dense that there's not even fat cells. You know, because you need fat in your palm.
Yes.
But that's in certain patients, and then in some patients they'll come in, and it's a totally different response to the surgery.
And usually how long it is between they are ready for surgery and they actually have surgery usually?
See, I can see so depending on the procedure, but I can see a patient and then operate 6 weeks later.
Yeah.
Now, in Canada, they can see a patient and operate 5 years later.
5 years.
Right.
5 years?
Yeah, for a rotator cuff repair.
Yeah.
That's the delay to treatment.
Oh, it's that public and private.
There is no private.
Oh.
So that's the delay to treatment. So, and this may help with your question, they do a lot of prehab,
Like,
right? Because they've got the opportunity.
that's what I'm thinking. Like if we add as they're ready for the operator, and they've got like 4 or 6 weeks in between.
That's
like
a
a little
perfect
bit
time.
time.
Yeah,
For
but it's still time.
Yeah.
But if you've got someone on a public hospital waiting list, so they say, oh, I'm waiting for something, and it's almost like they're like, well, I can't do anything because I'm waiting. You know, there's that sort of.
And I think often the people on the public wait list, if they get sent to the physio, they kind of feel like they're getting fobbed off anyway.
Yeah.
Yes.
You know, it's like,
it's like
I know the
oh,
time she
why
talks
would they
about
want
that,
to see
but
physio?
they,
But then physiotherapy can postpone their joint replacement by 12 months, you know, by building their VMO strength. So the physiotherapy helps, but I think we can, there's an opportunity there to say there's so much more we can do for you while you're waiting to make that surgery as optimal as possible.
Yeah.
It is the
Like,
cohort
just
though, isn't it?
once, like at least just once before the surgery they can go and see a physio. Like
Yeah.
still be on the list for surgery, but
Yeah,
just in between time they can do something
Yeah.
about it.
yeah, and yeah.
A bit of more education, like what to expect right after the surgery, when to put how much optimal weight, like just to prep them for that.
Yeah. Trying to, it's the time window in the consultation is the thing that I've struggled with the most.
Totally agree.
But it is the cohort as well that you say, as you say, like it's the people that come to you, or you know, the demographic, or like I know Orthosports in Sydney, when they've done research on the number of, say, total knee replacements they've delayed or prevented through their sports med physicians going through all the weight loss stuff with people and so on. But you need the people to want to do the weight loss.
Oh, you mean you need the motivated cohort?
Yeah, you need the patients.
But I think your point's valid in that we can't say we've got an under-motivated cohort when we've got poor medical literacy.
Oh, you have to get that. Yeah, 100%.
You know, we also have that responsibility for education, as you say. But how do we do that? We're probably not the people, as the clinicians. We can't be the clinician and the education provider as well. It's, you know, I understand we try our best, but we've got a responsibility to our community and our cohort to make sure that they've they've done as much education as we can supply. That's another story for my ramblings. Anything else? No other questions? You sure? You're full bottle on lymphedema. I think you find it very rewarding. I think that's why you do it.
Oh, that's the word I was looking for,
Is
rewarding.
it? Yeah, I think you
How do you say it?
the way you talk about it, you know,
Yeah.
it lights you up and you get
Yeah.
excited. And I just think that means that you that there must be a significant positive reward. And I think what you're saying is when you treat these people, they get much better. Yeah. And also, as you say, maybe there's a cohort out there that don't really even know that they've got access to this kind of
Absolutely,
treatment
Yeah,
and the opportunity.
yeah.
Thank you.
Thank you.
I agree.
Thanks for coming. Thanks for asking questions for other people. Thank you very much.